Myself Arvind, and topic is skeletal muscle relaxants. So first of all, skeletal muscle relaxants decrease skeletal muscle tone by peripheral or central action. Physiology of skeletal muscle contraction: first, motor nerve impulse, then release of acetylcholine, then binds with neuromuscular receptors at neuromuscular junction, then depolarization and development of end plate potential at motor end plate, then muscle action potential, contraction of skeletal muscle, then acetylcholine is rapidly inactivated by cholinesterase leading to repolarization, then muscle is ready for a fresh nerve impulse. Skeletal muscle relaxant is classified by two types: centrally acting and peripherally acting. Centrally acting drugs are diazepam and other benzodiazepines, methocarbamol, chlorzoxazone, tizanidine, baclofen, etc. Peripherally acting depolarizing blockers are succinylcholine. Non-depolarizing blockers pancuronium, doxycurium are long-acting. Vecuronium, rocuronium is intermediate-acting. Mivacurium is short-acting. Others are botulinum toxin A. Centrally acting skeletal muscle relaxants. Most of the centrally acting skeletal muscle relaxants are available in combination with one or other non-steroidal anti-inflammatory drugs. All of them cause certain degree of sedation. They act by depressing polysynaptic pathways in spinal and supraspinal sites. Neuromuscular blockers. Unlike centrally acting skeletal muscle relaxants, these drugs interfere with neuromuscular transmission, do not affect CNS, and are administered intravenously. Neuromuscular blockers include non-depolarizing and depolarizing blockers. Depolarizing blockers: succinylcholine. Succinylcholine is a quaternary ammonium compound. The structure resembles two molecules of acetylcholine linked together. It acts as a partial agonist at neuromuscular receptors, hence cause initial fasciculations and later flaccid paralysis due to prolonged depolarization. With continued exposure to the drug, the membrane becomes desensitized. That leads to phase second block, which resembles the non-depolarizing block and is partially reversed by anticholinesterase. In people with liver disease or atypical pseudocholinesterase due to genetic defect, the metabolism of succinylcholine becomes slow, which results in severe neuromuscular blockade, leading to respiratory paralysis with prolonged apnea. This is referred to prolonged succinylcholine apnea. There is no antidote available, therefore. Fresh frozen plasma should be infused. Patients should be ventilated artificially until full recovery. Adverse effects: muscle pain is due to initial fasciculations, increased intraocular pressure due to contraction of external ocular muscles, and it lasts for few minutes. Aspiration of gastric contents may occur due to increased intragastric pressure. Hyperkalemia: fasciculations release potassium ion into the blood. Sinus bradycardia is due to vagal stimulation. Competitive blockers: Claude Bernard showed experimentally the site of action of curare. Curare is a mixture of alkaloids and was used as an arrow poison. Among them, D-tubocurarine is the most important alkaloid, which has neuromuscular blocking activity. D-tubocurarine is the prototype drug of competitive blockers. Mechanism of action: acetylcholine is the agonist, whereas D-tubocurarine is the antagonist at neuromuscular receptors. Curariform drugs competitively antagonize the actions of acetylcholine at the neuromuscular receptors of the neuromuscular junction. Anticholinesterase are used to reverse the effect of competitive blockers by increasing the concentration of acetylcholine. Pharmacokinetics: neuromuscular blockers are quaternary ammonium compounds. They are highly ionized, hence poorly absorbed from GI tract. They are administered intravenously. They are mainly confined to ECF space, do not cross placental and blood-brain barrier. They are metabolized in liver and some are excreted unchanged in urine. Adverse effects: the adverse effects of non-depolarizing drugs are hypotension, respiratory paralysis, bronchospasm, and aspiration of gastric contents. Drug interactions of skeletal muscle relaxants: non-depolarizing blockers into antibiotics. Aminoglycosides inhibit the release of acetylcholine from motor nerve and potentiate the effect of non-depolarizing blockers, hence require dose reduction in patients treated with aminoglycosides. Tetracyclines and clindamycin also potentiate the effect of non-depolarizing blockers. Thiazides loop diuretics into non-depolarizing blockers. Hypokalemia caused by thiazides loop diuretics may potentiate the effect of non-depolarizing blockers. Succinylcholine into thiopentone. These drugs are chemically incompatible, hence result in precipitation when mixed in the same syringe. Factors affecting action of neuromuscular blockers: pH changes, metabolic acidosis and respiratory acidosis increase the duration of block. Hypothermia, it potentiates neuromuscular block by delaying the metabolism and elimination of these drugs. Myasthenia gravis, myasthenic patients are highly sensitive to competitive neuromuscular blockers. Aminoglycoside antibiotics, they potentiate the effect of both competitive and non-depolarizing blockers by inhibiting presynaptic release of acetylcholine. Inhalational anesthetics like halothane, isoflurane, and ketamine increase the effect of neuromuscular blocking agents. Uses: the main use of neuromuscular blockers is an adjuvant to general anesthetics for producing satisfactory skeletal muscle relaxation during surgical procedures in abdomen and thorax, orthopedics, etc. Succinylcholine is preferred for short procedures, example diagnostic endoscopies, endotracheal intubation, and orthopedic manipulations. Succinylcholine is used during electroconvulsive therapy to prevent trauma due to convulsions, for tetanus and status epilepticus when not controlled by other drugs. Competitive neuromuscular blockers can be used. Reversal of neuromuscular blockade: atroponium or neostigmine, by increasing the concentration of acetylcholine, reverse the effect of D-tubochlorine and other competitive blockers at neuromuscular junction. Use of prior atropine administration is necessary to block the muscarinic effect of anticholinesterase. Directly acting skeletal muscle relaxant. Dantrolene is a directly acting skeletal muscle relaxant. It inhibits depolarization induced calcium ion release from sarcoplasmic reticulum and produce skeletal muscle relaxation. Intravenous dantrolene is the life-saving drug in malignant hyperthermia. Botulinum toxin A, it is obtained from Clostridium botulinum, a gram-positive anaerobic bacterium. The toxin prevents release of acetylcholine into the synaptic cleft by inhibiting proteins necessary for the release of acetylcholine. Thank you.